them to finalize those policy, but implementers, if they are not in the process, so they will implement as they want, and again there will be a problem. These three entities should be in one platform. So in India, the HIS system is good, but there are around 1,000 service providers. Some hospitals has their own technical staff. Some hospital purchase the system from outside. And again, the platforms are different. So the standard should be standardized, like HL7, SNOMED, CT, HIPAA, ICD-10. All these standards should be incorporated. So many hospitals has HIS system. What they use billing, accounting, and store management. They call it as a HIS system, but there is no medical records. They are not using medical records in their HIS system. So HIS system should include medical records. Then only we can call it as HIS system. So two HIS system, right now two HIS system are not talking to each other, and they never want to talk to each other, because many hospitals don't want to share their patients' record to other hospitals. So they should talk to each other. Why hospitals are not utilizing, using this HIS system? Because the cost and expenses. Project implementation is not there. There is no mapping. Complexity, they think if we use the HIS system, again it will be a complex for doctors. They will not do this, and resource expertise is not there. So all these standard, if we bring together, then it can be a good system. Now we are talking about the privacy. In India, this is the situation. So privacy is not there. So we should think on this in India, basically, because there are so many patients in line. So challenges are there with the entities. Those are unmet needs. But again, there are some benefits of this EHR system. We have implemented RSBY and Aadhaar properly in India, in most cities. So we can use those systems, like RSBY, we can use their ID, their card as a health card, because it contains only the insurance details. They are using chip in that. So in that chip, we can store those records, and Aadhaar number can be a unique ID number for their records. So Denmark has implemented this. All the citizens in Denmark has their medical records on the system. So there is a national health record system, and national patient index is properly managed. So they have many much benefits in this system. So again, unique identification, like Aadhaar card, we can use that. The demographical details we can use. Then patient management in front office, we have to use that. Patient can be registered anywhere, and the records can be available anywhere. So waiting room, they can book an appointment through mobile app. So it will reduce the waiting time. Quality and quantity of staff we can provide in this. And dashboard reporting, like the city will, different taluka places are reporting to state, their state officers, then state officer reporting to national officers. Again, we can reduce the time, and per day we can get reporting from the hospitals. So we have a 5-minute infographic video. So yeah, it's there.
Yeah, just one. Yes.
Yeah.
Nilesh, can we stop this because we don't actually allow some promotion, yeah? Thanks. It's an interesting presentation on the electronic health record, and if you have questions for Nilesh, you can ask.
Nilesh, what's the size of the chip? I mean, what's the storage size of the chip?
It's a 64K Costa chip. So only emergency records are there, and all other information is stored on cloud.
Okay. And second thing, for example, if I have met with an accident, it's in my purse. How will the other person take it from my pocket and then insert in the PC? Because the chip will not get inserted. You need a flap to open in form of a chip in India.
No, basically it's a cloud-based technology. So there are instructions for doctors. So with this 16-digit number, a doctor can access the emergency
I'm
records.
talking about an accident. In Chandni Chowk, I met with an accident. Someone takes my card, puts in a PC, because it's 64, it has a small data. How will I put in the PC first?
So it's not required. It's for authentication, and it's not required for every time. If there are chip card readers, then it will authenticate directly without your password. The doctor can access your data. But it's a HIPAA compliant system. So without patient consent, doctor cannot access his records. So
I am unconscious.
Yeah, you are unconscious. So your emergency records can be accessible to doctors with this 16-digit number. So he will log in to the website and he will view.
Doctor is not there, nor is the connectivity in villages or let's say Chandni Chowk area specifically.
So basically the system is designed on a cloud platform. So without the connectivity, obviously there's no magic.
No. If connectivity, assume let it be there, how will I insert this card in the computer?
So basically you do not need to insert the card as such.
Okay.
So the 16-digit number that is there on the card serves as the ID. So there are two ways by which a doctor gets access to the system. One is with the appointment-based module where you have to take an appointment and then you provide a particular consent and get into the system. If not, in particular way, there is a walk-in patient module where you insert that particular number and doctor gets a read-only access to a certain amount of information, like your allergies or whatever is needed in emergency information. Obviously, that's our particular workflow we've designed. But in that particular condition, doctor cannot actually edit the system without the consent of the patient. So once the patient is in a conscious state, he can always make a conscious decision and tell the doctor whether he wants to get those updated or not. But obviously, the patient care cannot exceed e-health. So patient care is always our first motto, and then.
So it's on a very basic assumption that internet connectivity is 24/7.
I'm going to help him to answer this question, sorry, if I'm going to add to something. See, these e-health cards are something new in our country, but globally, these e-health cards with a kiosk are used for taking an appointment. There are kiosks on which you just put this card and you can take an appointment. They're also used as kiosks for teleconsult. So I put this card on a kiosk which also has a screen, and the moment I put this card, the data of that it's Nina goes to the doctor, and there's a teleconsult who actually which happens. So this is possibly, and I'm not trying to, I didn't even know this company, I'm not trying to do a marketing for this, but the concept of this card it's just a beginning. So this has application, and I think the reason maybe we are talking about this is that this could be a beginning to a different kind of a healthcare, a different way of taking appointment. You don't need to reach AIIMS and take appointment. You take appointment wherever in the world you have kiosks, like maybe ATM kiosks.
See, 95% patients die in road accident because they don't get the golden period opportunity to get them the blood group which is required.
So
And this card, you just can't take it and put it somewhere, and if the internet connectivity is not there.
So the way we have handled that particular workflow is that we are present on Android, iOS and other platforms as well. So basically, when you get the access to the app, there is the information in the app as well. So there is some way or the other you actually need to get the access. For example, in unconscious state, it's highly impossible for the patient to actually get up and tell that, okay, I need this blood group. And that's the reason we've kept the blood group on the card as well. So photograph, blood group and ID. So all three match.
Just to answer without cloud, I think Malaysia started it almost 10 years before when the cloud did not exist. So what they did was, the flow was like every hospital, when the discharge happens, they should write a minimum information into the card itself. Okay? If the patient goes to any clinic within that MOH stuff, the doctor need not actually wait for that because there was no flow at that time. So, I mean, we have to come with the option of how partial data can go or when everything can go. Some of the information can be there in the card itself. You don't have to really, but you need a reader for it, of course. Yeah.
Thanks. I think we'll not put cross examinations, just questions is done. So we are running into lunch time, but before food, there's food for thought. We have Dr. Sanjeev Kumar, who is the Executive Director of National Health Systems Resource Center. They are setting up a wonderful platform for health innovations, and he wanted 2-3 minutes to speak about it.
Thank you. First, I want to thank Rajan Gupta for putting this group together. And when I came, I've been feeling very excited that we can all connect and hopefully have a much positive impact on improving health in India. Maybe a little bit about the organization I work for. It's called National Health System Resource Center. It was created by Ministry of Health to provide technical support to Government of India, Ministry of Health, and also to the state governments across the country. For this, we have 8 divisions and 1 sub-office in Guwahati. And out of the 8 divisions, 1 division which looks at healthcare technology is the one which is related to the work for which we are here. And this division does 2 important things. One is it is looking at specification and standardization of medical devices and equipment in the country. And we have already finalized 169 devices. Standards have been approved by the ministry. And the next step from that is it goes to PGSND. Then they get into contract rate, and anybody in the government system doesn't have to go for bidding. They look for this agency and they can buy the equipment. It does 2 things. One is the bidding process is cut short, equipment can be bought. And the second thing it does is the cost has come down substantially. To give you an example, in Maharashtra, the cost of buying ambulances came down by 400 crores. So it has that dual benefit. The second thing which we are getting into, or maybe before I get there, biomedical equipment maintenance in public health system is amazing. 2/3 of the equipment, that's the figure we have from most of the states in the country, is at any given point of time is out of order. So what we have done is a standard contract